Okay. Good afternoon, everyone. You're very welcome to this ESNM GMFH, or European Society of Neurogastroenterology and Motility, and Gut Microbiota for Health subsection webinar series on Clostridioides difficile. And today we have one speaker. We had been scheduled to have a talk on the clinical features of C. diff infection, but unfortunately our speaker couldn't attend. So today we're delighted to have Professor Frédéric Barbu from Paris in France, who will be talking to us about laboratory investigations. And I'll mention this in a moment. So first of all, just a little bit of housekeeping before we get started. Firstly, we'd like to thank our I'll just check the chat here, make sure. Yes, that's just the recording will be available, so I'll mention that later. So this will be recorded and it'll be put up on YouTube. So thanks for the question. So first of all, we'd like to thank Ferring Pharmaceuticals, who are supporting this webinar series in 2022. Just for a bit of orientation of the Zoom format, in case you haven't used it before, if you wish to ask a question, you can use the Q&A function. So this is what it looks like on the desktop, and this is what it looks like on your mobile phone. So if you post any questions to the Q&A section, we'll be able to ask or deal with those, address those after the presentation. So that's the Q&A there. If you have any general problems during the session, just post something into the chat, and if we have to address it then during any technical issues or so forth, we'll do that during the talk. So thank you again to Ferring, and then just a reminder that the webinar is being recorded, and the series has been posted on YouTube, and it'll be uploaded afterwards. And don't forget the rest of our series. The next talk is treatment options for C. difficile infection, and that will be on September 6th. So that's just a date for your diary. So I'll just stop sharing and introduce our speakers. So we're delighted to have Professor Frédéric Barbu from Paris, France. Professor Barbu is a professor of medical microbiology, head of the infection control unit at Hospital Saint-Antoine in Paris. He's head of the National Reference Laboratory for Clostridioides difficile infection, and deputy director of the INSERM group Pathophysiology and Pharmacotoxicology of Human Placenta, Pre- and Postnatal Microbiota. Professor Barbu is really a global leader in characterizing the epidemiology, phylogeny, genomics, virulence, diagnosis, and ecology of C. difficile infection, as well as many other healthcare-associated infections. He's also an expert in the application of molecular and sequencing approaches to studying infectious outbreaks, research in the infant gut microbiota, and he's a member of the French group for fecal microbiota transplantation. So we're absolutely delighted to have such a global leader talk to us today on Clostridioides difficile infection, laboratory investigations, when and how. So thank you very much, Professor Barbu.
Thank you very much for this very kind introduction. And thank you for inviting me to this webinar, which is dedicated to the diagnosis of C. difficile infection. So I will start this presentation by some brief data on the epidemiology of CDI, and then I will focus on technical aspects and methods currently available for the diagnosis of this infection. So as you know, C. diff is a gram-positive anaerobic spore-forming bacterium, and only toxigenic strains which produce two toxins. So as I said, C. diff is a spore-forming bacterium which is able to produce two toxins, toxin A and B, and only toxinogenic strains are considered so far as pathogenic. But you also have a non-toxigenic strains which are unable to produce toxin A and B, and they are considered as non-pathogenic, and they could even protect patients from the colonization by a toxigenic strain. So the clinical presentation ranges from asymptomatic carriage, which is 3% in adults, to C. difficile infection, which itself varies in severity from mild to moderate watery diarrhea to potentially life-threatening pseudomembranous colitis. So clinicians have to face two clinical challenges in the management of CDI. The first one is the evolution to a very severe complicated form, including the toxic megacolon, perforation, syndrome of septic shock. These complications are quite rare, less than 10% or even 5% nowadays. But the mortality rate is over 50%. And the second clinical challenge is recurrences. As you know, 10 to 25% of patients will present a recurrence in the 2 months following the initial episode. And the patient with the first recurrence has a higher risk for subsequent recurrences. And sometimes we face patients with 5, 6 episodes of CDI a year, and these patients are very good candidates for fecal microbiota transplantation. As you know, C. difficile is also a major nosocomial pathogen and is implicated in 10% of nosocomial diarrhea. So C. diff has a considerable burden on healthcare system, but the situation seems different from in US and Europe. In US, the estimated number of incident CDI cases is 223,000 per year, leading to 12,000 deaths, and it's considered as the first agent responsible for hospital-acquired infection. In 2019, the CDC recently categorized C. difficile infection in the highest priority category of antimicrobial resistant threats. And in Europe, as you can see on the right side of the screen, there is 124,000 CDI per year and 3,700 deaths. And during the European point prevalence study on a healthcare-associated infection, C. diff ranked 8th among pathogens responsible for hospital-acquired infection. So the epidemiology of C. difficile infection has dramatically changed over the last 10 and 20 years. Increasing rates of CDI have been reported in several European countries. And you can see on the graph on your right that there was a 70% increase of the incidence ranging from 4.1 cases per 10,000 patient days in 2008 to 7.3 cases per 10,000 patient days in 2012 and 13. So this change is assumed to be due in part to a combination of different factors, including, first of all, the dissemination of a hypervirulent NAP1-027 clone, but also a better awareness of CDI from physicians who request more frequently CD tests, and also the emergence and more sensitive method for the diagnosis of C. difficile infection, including nucleic acid amplification technique like a PCR. But the good news is that in some countries, the incidence of CDI and the prevalence of the epidemic clone NAP1-027 have recently decreased over the last few years, and this may be due to improved infection control measures and surveillance. Despite this increase, the underdiagnosis of CDI remains very important both within the hospital and among community cases. That has been documented in 2 studies. The first one was the Euclid study performed in 2012, including more than 480 healthcare facilities. And during this study, it has been shown that 23% of hospital CDI cases remain completely underdiagnosed. More recently, another study, which is called the Comeback CDI study, which was performed in 119 healthcare facilities, showed that there was an improvement of the diagnosis of CDI. Only 16% of hospitalized CDI cases remain underdiagnosed. However, there was a large proportion of underdiagnosis, more particularly the community cases remain in half of the case completely underdiagnosed. So there is some studies have shown that there was a correlation or an association between the testing density and the incidence, although this correlation was quite poor. On the graph on the left side, you have each dot represent a hospital according to the density, the testing rate, which is defined by the number of CD tests per 10,000 patient days, and according also to the incidence on the left side. I don't. Do you see my arrow on the screen?
Yes, I can see it. Yeah.
Perfect. Perfect. So you can see there was a correlation between the testing density and also the incidence of CDI. In other words, the more you test, the more you find. But more interestingly, on the right side of the screen, you can see that an inverse correlation was noted between the testing rate and the prevalence of ribotype O27 in the 4th quadrants in Europe, north, south, west, and east. In other words, in countries where the testing density is very high, the prevalence of the O27 was very low. And conversely, in countries where the density testing was low, the prevalence of the O27 was very high, which suggests that increased awareness of CDI and the use of optimum testing methods and policies can reduce the dissemination of the epidemic strains. Another trend in C. diff epidemiology is that CDI is no longer restricted to a hospital setting, and cases of community-acquired CDI are increasingly common. We performed in France this study with 2,541 direct stools from patients visiting their GP for gastrointestinal symptoms. And we systematically test for C. diff, irrespective of physician request. And we found that 3% of stool samples were positive for toxigenic strains, making this pathogen the second most common pathogen after Campylobacter. The CD testing actually was requested by GP in only 12% of cases, but this test was quite well oriented since physicians were able to detect more than half of the C. difficile infection cases. So the question now is which kind of cost-effective strategy should be implemented for diarrheal stool samples from the community? And according to our study, if CD testing had been performed in patients over 65 years or in patients with previous antibiotic or previous hospitalization, then only 29% of stool samples would have been tested, but and 70% of all CDI cases would have been detected. So this is one of the criteria we try to implement for stool samples, direct stool samples from the community to detect CDI, to test CDI. So let's move now to the guidelines for the diagnosis of C. difficile infection. As you know, the landscape of CDI diagnosis also changed over the last 10 years, and it requires a renewed attention. A rapid and accurate diagnosis is essential, both for patient management, but also for prevention of nosocomial transmission. It is also crucial to get reliable data to monitor the incidence within a ward or to compare the incidence across different hospitals. So the ideal criteria for a diagnostic method should combine a very high specificity and sensitivity. The method should be rapid, cost-effective, and technically simple. However, there is no single method which combines all these criteria. So guidelines have been published under the auspices of different scientific societies. The European Society of Clinical Microbiology Infectious Disease published their updated guidelines in 2016, whereas the American guidelines from the IDSA were published more recently in 2018. Before going through the technical aspects of the diagnosis, several rules should be respected for stool selection, and all these rules are uniformly recommended by the different guidelines presented on this slide. So the first rule is to test only diarrheic stools in order to avoid the identification of asymptomatic carriers and to avoid the overdiagnosis of C. difficile infection. And from the laboratory viewpoint, a diarrheic stool is a stool taking the shape of the container. So we suggest the laboratory to implement rejection criteria for all the stools which are not diarrheic. The second rule, as you can see here, is do not test stool samples from neonates because under the age of 3 years old. As you know, probably there is a very high asymptomatic carriage of toxigenic strain in neonates, which can reach 70% between 6 months and 1 year. And then the carriage rate drops progressively to have the adult carriage rate by the age of 3 years. So in my hospital, for example, we have a rule to exclude all the stool samples from the neonates under the age of 3 years old. Occasionally, CD testing can be performed only upon physician request and in very, very specific situations, such as neonates with a Hirschsprung disease or in case of an outbreak. The third rule is that repeated diagnostic testing is not useful. This is a very common practice. As you can see here, between 12 and 30% of stool samples are tested twice within a period of 7 days. But this practice should be discouraged because the diagnostic gain defined by the number of tests converted from negative to positive following a repeat test is very low, around 1 to 2%. So these data support the limited value of repeated testing, at least within 7 days of a negative result. The fourth rule, which to me is one of the most important, is that test of cure is not recommended. The definition of clinical cure is only based on improvement or cessation of diarrhea. As you can see on this graph, after discontinuation of metronidazole or vancomycin therapy in patients with CDI, you can see that C. difficile spores are still detectable in 7% of patients at the end of treatment, and as many as 56% of patients who remain asymptomatic have a positive culture 1 to 4 weeks after the end of therapy, despite resolution of symptoms. So that's why that test of cure is not recommended. And finally, stool samples should be taken prior initiation of CDI treatment. This is a general rule which is available for all the microbiological specimens. In this study performed by SETI, they took 51 patients with CDI and they test all the patients every day until day 10 after the treatment. And you can see that for PCR, for example, in the black line, 14, 35, and 45% of positive CDI tests converted to negative after just 1, 2, or 3 days of treatment, respectively. So that means that empirical therapy may result very quickly in false negative results, and this suggests that a rapid laboratory test result may reduce empirical treatments. So let's move now to the technical aspects of the diagnosis, and this slide gives you an overview of the different testing methods for CDI, and the available tests fall into 3 groups depending on their target. The first group will detect the presence of C. difficile in stools, either by anaerobic culture using selective medium or by detecting a specific enzyme called glutamate dehydrogenase, or GDH, which is not specific from toxigenic, but also present in non-toxigenic strains. The second group of methods detect the free toxin, the protein, or its biological activity, either by enzyme immunoassay for toxin A and B, rapid immunochromatographic assay, as you can see here, or by the cell cytotoxicity neutralization assay on cell culture. And finally, the third group of methods includes detect the presence of C. difficile with its capacity of producing in vitro the toxin. And these methods include the nucleic acid amplification technique, the PCR, detecting both the gene for toxin A and B, or the toxigenic culture. So currently there are two reference methods, which are the toxigenic culture and the cell cytotoxicity neutralization assay. As you can see, they have different targets, and therefore the results are not directly comparable. And paradoxically, these methods are not used routinely in the lab because this one is quite complicated. You need cell culture facilities, and this one, the toxigenic culture, is quite long to be performed. This figure summarizes the advantages and drawbacks of each of the different methods. First of all, for method detecting free toxin, they are very specific of C. difficile infection. However, the ERA for toxin have a low sensitivity, and therefore you can miss a lot of CDI infection. For the method detecting the presence of C. difficile in stools by culture or GDH, these methods have an excellent negative predictive value. So a negative result will rule out the diagnosis of C. difficile infection. However, they have a low specificity because these methods are not able to distinguish between toxigenic or non-toxigenic strains. And finally, the method detecting the presence of a toxigenic strain are very sensitive. However, they lack specificity because they cannot discriminate between true C. difficile infection or patient with a carriage of a toxigenic strains. Okay, so one of the major challenge currently, and the main, I would say, the main dilemma currently is the clinical significance of a patient with a positive toxigenic culture without any free toxin in the stools. And this issue was resolved or addressed by Team Plunge and collaborators who analyzed more than 10,000 patients suspected of having CDI. And they divided this population in three groups. One group of patients with a free toxin in the stools, one group of patients harboring a toxigenic strain without any free toxin in the stool, and a control group free of C. diff, negative for C. diff. And they compare the mortality and the WBC count of this patient. And you can see on this table that mortality rate and WBC count was significantly higher in the group of patients with free toxin compared to those harboring a toxigenic strains, suggesting that the presence of toxin was significantly associated with poor clinical outcomes. However, if you compare group 2 and group 3, you see that there is no difference in terms of mortality or WBC counts. So the presence of a toxigenic C. difficile in feces in the absence of a positive toxin assay was not associated with any significant clinical outcome worse than that of a negative sample. So the best method for a true diagnosis relies on the detection of free toxin in the stools. And that was confirmed recently in the COMBAC study, where the mortality rate of patients with CDI having free toxin in the stools was significantly higher, 15%, compared to those harboring a toxigenic strain without any free toxin in the stools, 9%. So based on these observations and the fact that no standalone methods have an adequate positive predictive value at a low CDI incidence, the ESCMID proposed to implement a two-step algorithm to overcome this problem. So this two-step algorithm usually starts with a very sensitive method. In case of negative result, you can rule out the diagnosis of C. difficile infection. In case of positive result, you must confirm this the diagnosis with a method, a highly specific method detecting free toxin in the stools. And if positive, then CDI is likely to be present. Some companies rapidly propose a test which are able to detect the GDH and free toxin simultaneously in a single test. So this is what we call a combined test. If both targets, GDH and toxin, are negative, then the diagnosis can be ruled out. If both tests are positive, then CDI is likely to be present. And the interpretation of GDH positive, toxin negative is a little bit more complex because it can be either the detection of a non-toxigenic strains, or it can correspond to the detection of a toxigenic strains with a level of toxin below the threshold of detection. So that's why we recommend to use as a second technique a NAT, a nucleic amplification test, which would be able to resolve the patient with non-toxigenic strains in case of negative results. So the IDSA guidelines are quite in agreement with the ESCMID guidelines and propose a strategy depending on the pre-agreed institutional criteria of patients to submission. In other words, they propose a two-step algorithm, but also give the opportunity of using a nucleic acid amplification technique, a PCR technique alone, whenever selection of stool specimen is strictly implemented by the clinician and the laboratory personnel. Recent publication also indicated that the bacterial load of C. difficile determined by the CT with a PCR test is correlated to the toxin detection and the severity of the disease. Actually, there is one study performed by Monique Robach and collaborators who sought to determine whether a preliminary diagnosis could be made on the basis of the quantitative result estimated by the CT value of the first test in an algorithmic testing. So they made a retrospective analysis of two large collections of samples of patients suspected of having CDI. Among these patients, 200 and 100 samples were tested positive by NAT, and they compare, as you can see on the left side of this slide, the CT from patients with free toxin on the right and those with negative free toxin on the left. And you can see clearly that there was a CT which was lower. So it means that the load of bacteria of C. difficile was higher. So the CT was lower in patients with free toxin compared to those without free toxin. So they use a ROC curve analysis, and they show that the best cutoff value was 25 to discriminate those positive for toxin and negative for toxin. However, they conclude that the CT values can serve as predictors of toxin status, but due to the suboptimal correlation between the two tests, additional toxin testing was still needed. And finally, I would like to give you some data about new perspectives in the diagnostic testing and a new technology for detecting toxin in the stools. This technology is called SIMOA, single molecule assay. It consists of toxin capture by specific antitoxin A and B antibodies coated on paramagnetic beads. And then it is followed by a detection with a specific antibody conjugated to a beta enzyme, galactosidase, for example. And the third step is that beads are incubated with the enzyme substrate and individually isolated in microwells of an array for digital imaging. So this test is already commercially available in US. It's the Clarity C. difficile toxin A and B. This test has a very, very low limit of detection for both toxin, 2 and 0.5 picogram per ml for toxin A and B respectively. And the clinical evaluation was recently performed by Sandlun in US. They compared the result of this test to a two-step algorithm based on the expert as a screening method, followed by EIA for toxin A and B, and in case of negative result by the cytotoxicity assay. And they showed that this test have 97 sensitivity and 100 specificity compared to this two-step algorithm. So that was a very ultra-sensitive toxin assay, which can be automated, very rapid, less than half of an hour. And potentially, it will replace in the future the multi-step testing algorithm as a reference method. But we need more evaluation in the future. So in conclusion, selection of stool samples is absolutely essential for an accurate diagnosis and in order to avoid any empirical treatment before stool samples. Rejection criteria of stool samples must be implemented at the lab level. It's very important. No single methods have an adequate positive predictive value at a low CDI prevalence. That's why a two-step algorithm is currently recommended by European guidelines and American guidelines. And finally, I would say that the result of CD testing should be available within a day in order to treat appropriately the patient. Thank you very much for your attention, and I'm ready to take the question if you have.
That was a terrific tour de force. Thank you very much, Professor Barbu. Really, really terrific. I might just stop your slide sharing if that's okay.
Yeah.
I'll just remind our participants that there's the Q&A box at the bottom of their screen, and just please put any questions you have for Professor Barbu into the chat there, or into the Q&A box, sorry, and we'll address them. I do see that somebody had a little bit of a difficulty with the same hanging on the same slide, so it was fine for me. I noticed it's a Galaxy S9. Sometimes the web browsers stall on the phone, so perhaps that was it. But just to reiterate that this presentation will be available on the ESNM website afterwards, and I'd encourage you, if you missed any of the data that was presented. So please, there's plenty of time to put anything in the Q&A. I've a couple of questions. I might just get the ball rolling. And just again to highlight to anyone who came late, we only have one speaker today. The first talk, the speaker was unable to attend, but we did touch on some of the Professor Barbu did touch on the clinical presentation at the beginning. So one question that I had, it was very interesting, the data on the toxin, free toxin versus patients who don't have any free toxin detected, and the difference in mortality. Is there any move or benefit to looking at quantitative toxin levels for predicting prognosis? So I know this is moving more into the prediction side of the actual clinical course in these patients who are toxin positive, but it suggests that maybe quantitatively, if you have a lot more toxin than someone else, that you might have a worse course. Is that a reasonable idea, or is there any evidence to back that up?
No, there is no data which suggest that quantification of toxin might be useful to predict the evolution to a more severe form of the disease. What we know is that usually when you have a pseudomembranous colitis and a very severe form of the disease, you have quite a large amount of toxins. But there is no data on the predictive value of quantification to predict the evolution to a severe form.
Okay.
Also, we know that, of course, free toxin is actually the key point for the diagnosis of CDI. However, I must say that in my experience, and I'm sure that in the experience of the other people, that sometimes we have people with no free toxin in the stool samples and harboring a toxigenic strains and responding to a treatment by vancomycin, and probably these patients are truly infected by C. diff. The reason why we don't have free toxin is quite obscure, maybe because they have a low level of toxins, because the ERA have a low sensitivity, and or because the toxin has been degraded during transportation of the stool sample. It is also a possibility.
Okay, Okay, brilliant. That's terrific. And we have a Q&A question here, which I'll just read out to you. As a public health dentist in the US and recent survivor of C. diff following a dental procedure and antibiotics, why are dental clinics or private practices overlooked as outpatient settings are not included in CAI? This often delays testing, diagnosis, or causes misdiagnosis. So an interesting question there about the outpatient setting.
Yes, this is a very interesting debate, because for a long time, C. difficile infection has been considered and restricted to the hospital and nosocomial diarrhea. And more recently, we get aware that C. difficile is also a very important agent of community-associated infection. And probably many patients having a treatment by antibiotic, for example, before dental procedures, may develop a diarrhea, but usually this diarrhea is very mild or self-limited, and this diarrhea is not investigated, and the patient will improve, I would say, naturally, without any specific treatment by vanco or metronidazole or fidaxomicin. So, but sometimes we have patients without any hospitalization, without any previous antibiotic, presenting at the emergency department with a diarrhea, and the diarrhea is due to C. diff. So I think the key message is to think systematically about C. diff in front of a patient with diarrhea, whatever the history of the patient, because this is a very frequent pathogen. And it's just during our study, it was the second most frequent pathogen after Campylobacter. So before Salmonella and before Yersinia and before all the virus. So this is a very major pathogen. So please think about it and don't hesitate to ask for CD testing.
Terrific. And thank you for that excellent question. I suppose just following on a little bit from that, we know that screening tests are susceptible to the baseline prevalence and so forth. So do you think there's any indication for screening patients on admission to hospital, particularly in areas with a high prevalence or a relatively high prevalence, and isolating them then? Or is this a worthwhile endeavor?
No, this is not recommended by the ESCMID recommended guidelines for infection control to screen systematically on admission patient for C. diff. However, that is true that the asymptomatic carriers of toxidogenic strains can disseminate their spores in the environment and can transmit the spore to other patients. But the environmental contamination of the asymptomatic carriers are very inferior at the contamination of the direct patients. The only circumstances where screening might be an indication in when you have a large outbreak of CDI in a ward, then in this case, probably you can eventually screen the patient on admission and every week to know the transmission rate and to trying to elucidate the mechanism of transmission. Okay. But this is the only indication. Usually you don't have to screen asymptomatic patient, because one of the reasons, what I didn't mention it, is that treatment by metro, vanco, or fidaxo of asymptomatic carriers is totally unuseful, because you can't eradicate the carriage by antibiotic.
Yeah. Yes. Yeah. Yeah. A great point. And also just a follow-up comment from our comment there in the US, that many many patients don't equate their dental visit or antibiotics with their symptoms, and dental practices do not use disinfectants that kill C. diff spores. So
that is true, but usually, I mean, the chronology of patient visiting their dental practitioner is that the dental practitioner will prescribe antibiotic and the patient will develop later on the diarrhea and will contaminate the environment later on. I think there is no indication for disaffecting the environment of the dental cabinet house.
Terrific. Okay, we'll be wrapping up. I have maybe just one more question, just on that last thing for myself. You mentioned these new, the Singulex, the new ultra-sensitive techniques. Do you think that these will be replacing the complex algorithms, or do you know?
My personal viewpoint is that this is an improvement compared to the ERA, but it will provide another issue, is that which level of toxins you need to conclude that the patient is truly infected, and rather than simply a carrier, because it's so sensitive that you can detect very low quantity of toxin which are presented as asymptomatic carriers.
Sure.
So the next problem issue will be to define the cutoff from asymptomatic carriers and true infected patients.
So you just shift the problem to another place. Yes. Okay. So. Well, I think that was an extremely comprehensive presentation on a topic that I think it's very clear that the clinical community needs a lot of education on, and also the general public. So I would encourage you to review this data. If any of you are clinicians and are in general medicine or anywhere indeed dental or whatever, please do share this. It will be up online. Extremely important information. As I said, we only have the one speaker today, so I'd like to, on behalf of Ferring, who like to thank Ferring for sponsoring Pharmaceuticals for sponsoring this webinar series. I'll remind you that the next presentation in the series is on the 6th of September, and that will be on treatment options in C. difficile infection. Let me just make sure I have that right. Yeah, 6th of September. Again, I would like to thank Professor Frédéric Barbeau for a wonderful talk, and everyone at ESNM and Gut Microbiota for Health.
Thank you very much for your invitation.
Okay.